Welcome everyone. We'll get started in a few minutes. For those of you on the call already, muted your lines to reduce any background noise. Thank you, and we'll be back in a few minutes to start the webinar. Good afternoon, everyone. Welcome, and thank you for joining the CQC team for today's webinar, COVID-19 Peer Sharing Telehealth for Small Practices. We are delighted that you all are here to join us today. And before we get started, I would like to remind you that this session is being recorded and will be available to you 1 to 2 days after the webinar is complete. We will be sending the presentation slides, the recording, as well as any URLs or any other resources that come out from today via email to all registrants. Before I would like to review a couple few Zoom tips. All attendees are muted upon entry to ensure no background noise is coming through. If you are joining through a phone, please refrain from using the hold button, as we don't want to hear any background music. If you're having any technical issues with your audio or video, please direct your messages to me, Jose Ordóñez, and I will do my best to assist you. Also, we would like to remind participants and also please consider to not use your video. Zoom is experiencing a lot of overload right now, and this will reduce any bandwidth problems. And if you have any questions or comments, please utilize the chat box and we will moderate and answer as best as we can. During today's webinar, we will have sections where you can unmute yourself. And this, at the bottom, you have a toolbar where if you have joined through a computer, you can unclick the microphone icon right here that you see, and that's how you will be able to unmute or mute yourself. If you had joined through phone, you can also click in the phone icon, or you can simply press *6. Also, throughout the webinar, we'll be asking you a few poll questions. So please make sure to submit your question by just selecting one of the answers here. And then at the end, click submit, so the pop-up window that will appear will disappear after. At this time, can we please have all the participants add their names and organizations to the chat box, please? Lots of people joining from different organizations. Great, welcome everyone. And as you keep doing that and presenting yourself, to get started, we have our first polls for the day. And I'm gonna launch them. We would like to know, where are you dialing from? And also, what type of organization are you part of? I'm gonna have a couple more seconds, so 20 more seconds. Please make sure to submit your answers by clicking the submit button. And okay, I'm gonna stop, share the results. So we have a lot of people from the Bay Area, great. That's where we are from, Pacific Business Group of Health as well. And we have a couple organizations, most of them are IPA, which is great, and a couple other ones as well. Well, at this time, I'm going to turn it over to Chris.
Hi, good afternoon, everyone. I'm Chris Jaeger, the Vice President of Care Redesign for CQC. Thank you all for joining us today. It's great to see such a great mix of individuals from a breadth of organizations. CQC's role today is as a convener and facilitator of the identification of best practices. And this webinar builds upon the conversation we had 2 weeks ago, getting more tactical this time about successful practices and lessons learned, while also doing our best to be intentional and strategic about making telehealth part of the future of standard clinical care delivery. It's meant to be an interactive session, so please don't be shy about unmuting and contributing. Next slide, please. Our objectives are noted here today. I'll let you read them to yourselves. Importantly, the scope of telehealth for our discussion today includes synchronous telephonic as well as audio video visits, but not other modalities such as asynchronous e-consults and other means. And we'll be calling out resources later in the webinar, but please make sure to access our website for resources as well. The link's at the bottom of this slide. Next slide, please. So we'd like to ask a question and have you chat in responses. Given that we are doing a deep dive in telehealth today, we wanted to open it up and see if you could try to summarize in 3 words or less what you are hearing from your practices as they are taking on telehealth. We'll give you a moment to do that. Important but challenging, very true. I think that summarizes it well. I'll move us along to a couple of quick polls. Next slide, please. The first poll we'll post is, to what extent have your providers changed from face-to-face visits to telehealth visits in the recent weeks? Jose, you can give us a warning before we wrap up the poll, please.
Yep. We're gonna give 30 more seconds. Please make sure to click the submit button for your answer to be recorded.
A couple more good comments came in. Useful but disruptive. Not as engaging as face-to-face. All very good comments. Thank you.
5 more seconds. Okay.
Great, we have both results in. So, boy, 77% doing over 50% with 36 over 75%. That's impressive in such a short amount of time. And then the telehealth visits being done by providers, a mix here, about a third in each bucket of 75, 25, 50, 50, 25, 75. That's great to see. We'll be anxious to hear some more kind of spoken comments, especially from those doing 75% audio video as we move on through the webinar. I'd like to turn it over now to Christina from our team. She'll walk you through some more polls and the rest of our agenda. Thank you.
Great. Thanks so much, Dr. Jaeger. So this is Kristen Amodi. I am Senior Manager of Improvement Advising at CQC. And I wanted to just mention about that last poll that although there were, I think, more telephone visits than video, on our last webinar, we heard several IPAs and practices mentioning that they're looking to transition more to video. So hopefully we'll hear some tidbits today from either our speakers or other peers on the line. So one thing that we at CQC have been doing that Chris mentioned have been collating and curating resources on our resource page. And we also asked you all when you registered for today's webinar, what are the most impactful resources around implementing telehealth? And so given that there are so many to wade through, we wanted to call out 3 today. The American Medical Association resource was called out by several of you as a really fantastic sort of start here with many different aspects that practices can, consider, from pre-planning, vendor and platform assessment, workflow, and then telehealth etiquette. The California Telehealth Resource Center also came highly recommended, and this is one presentation that kind of walks through many of the beginning considerations when you're starting. And then we heard many times from those who registered from this webinar that CMS has done a good job providing information and resources. So we encourage you to check out the telehealth and telemedicine toolkit. And I also learned from one of you who registered for this webinar that they are conducting office hours stakeholder calls. So we posted the future and past call links and call information here. So I believe Michael will be providing that in the chat as well, and it will be in our on our resource page shortly. So a couple other honorable mentions about resources, because that's a broad word. Entities called out that proactive communication to communications that telehealth as a service is available, and then texting reminders to patients prior to the visit. Those are both really useful tactics. Another resource that is invaluable, an office champion who wants to make telehealth work, which is very hard to duplicate, but just a fantastic asset. And then finally, I wanted to call out this one because this is what CQC is here to support, are peer sharing venues to learn from others. So we agree that during this dynamic time, it's always great to bring together entities who are doing the same thing, maybe a little further ahead, and learn from them. So what I would like to do then, before I turn it over to our speakers, is to quantify some of the sentiments your provider organizations are feeling around telehealth. So just another quick pulse check. Generally, and Jose, if you wouldn't mind launching this poll, generally our providers are very unsatisfied, unsatisfied, neutral, satisfied, or very satisfied with providing care via telehealth. And this is a question, I should say, that would likely change, maybe 3 weeks ago to today to 3 weeks from now. So definitely an answer that will change a lot. But what I'm seeing, and we'll give a few more seconds to this, is a lot of satisfaction actually, which is great to see. And it kind of reflects some of the 3-word answers that we got earlier in the meeting, which is this is important but challenging work, and it's useful but disruptive. So both those sentiments can be true. So let's go ahead, Jose, and show some poll results. Yeah, so what we have are the majority of your providers are actually satisfied with providing care via telehealth, which is just a great sentiment to build on. So with that intro, I'm very, very pleased to introduce our guest speakers. Both of them were kind enough to share on our previous CQC webinar 2 weeks ago. We're really excited to hear from Jessica Voigt, who's the Director of Outpatient Clinical Nursing with Desert Oasis Healthcare. And then we'll hear from Christopher McGlone, who's the Chief Operating Officer with Sharp Community Medical Group. Both speakers will have about 15 minutes to share their experiences and perspectives. And feel free to pose clarifying questions to them in the chat, and they'll do their best to answer at the end of their segments. And then we'll have some time for general discussion and peer sharing. So with that, I'm really excited to turn it over to Jessica.
Hi, everyone, and good afternoon. Thank you so much for CQC for providing this opportunity for us to do some peer sharing. We really do appreciate this highlight and the ability to kind of share what we've been through over the last couple weeks. So really, I just wanted to kind of start out and tell you guys a little bit about our organization. So Desert Oasis is a full risk HMO with about 60,000 lives that we cover, over about 100 primary care providers. Now, some of these primary care providers are going to be in the IPA, but we also have kind of a unique subset where we have some employed physicians as well. And these are primary care providers as well as some specialists, which is actually where the realm that we kind of come into for my team is with those employed physicians. And essentially what we do is try to build a model that works for our employed physicians, and then utilize it as kind of blazing the trail for our IPA physicians that we have, or our contracted providers that we work with as well. So we really help to lead them through that process with lessons learned, much like what we're doing here today. And one unique thing about our organization is that a majority of our IPA providers also share the same electronic health record. So in that aspect, we're kind of a unique process where there are many different touch points throughout the system that are viewable across the continuum of care for the patient. And this may be from an urgent care setting or our immediate care locations to primary care, some of our specialists, but also further outreaching the collaborative care team to include pharmacists, to also include case managers, and kind of a case management practice as well. So as we continue to kind of develop this, we are looking further outside the realm of just primary care visits to really look at how we expand this into the collaborative care team. So, another thing about our organization is that we're about 50-50 senior to commercial members. So our population is kind of unique in that we have a very large Medicare Advantage representation for our patients. So about 50% are going to be over the age of 65. So you can imagine the comorbidities, the difficulties with technology, and kind of some of those things that we've been overcoming, especially with this patient demographic. So that's a little bit about us. For telehealth implementation, it really all started on March 30th, where we kind of got the edict to say, hey, let's move forward. So we've been doing this now for about 2.5 weeks since we started, and it's a collaborative group. And what we did is chose a system called LifeSize that is focused on doing our virtual visits, and we have leveraged what other technology we had as well. So we are utilizing Well, which is our appointment reminder system and our two-way secure texting with our patients. So we're kind of leveraging both platforms to really reach our patients the best that we can. So we really started on the 30th of March with a motivated team. And by April 2nd, we were seeing our first patients via telehealth. So really within 4 days, we just kind of hit the ground running. We had established a workflow that would work best, leveraging those two platforms, and then just pushed it out. And it was more so an all hands on deck, let's learn as we go kind of shotgun approach that we've had great success with. Since then, we have been able to launch with 250 employees on this platform, both employees and providers to facilitate the team. And we've conducted over 500 visits. In fact, yesterday, in one day, we had a little bit over 200 visits throughout the organization for our virtual visits. And these are all, we have chosen the term virtual visit and telemed to differentiate between the live video and the telemedicine. And that was kind of chosen early on because it was an event type we could build within our electronic health record and our practice management side of things, or the scheduling component. And so we really established those two terms to move forward. And it was important for us to establish those two terms because when we were pushing out a marketing campaign, we wanted to make sure that everybody was speaking the same language. So there was some discussion regarding telehealth, telemed, and some other concepts. So we really kind of tried to stick with a universal term or universal terms as we move forward. So you'll hear me use the term a virtual visit as well as telemed. So I kind of wanted to get that clarified up front. I will say, much like you had said with the honorable mentions, really the success has largely been due to daily meetings. So we're having a daily 2 p.m. virtual visit huddle where we actually utilize the platform to perform the visit, perform the meeting. So we actually all log on to LifeSize. And what it does is gives us the opportunity to build confidence in utilizing the platform so that we can continue to push that out. And then most definitely leveraging super users or really content experts, and developing those content experts has been what's created this, created our success and what we have seen with the success for this. The super users are motivated. They also know their patients. So that has really been helpful to leverage that aspect of it. The next question on here that we have is really looking at the types of visits. So right now we're really kind of focusing on PCP visits, new patient visits, some are same day appointments, and we've actually have our specialty practices up as well. So rheumatology, neurology, podiatry, cardiology, and as I mentioned, pharmacist support, as well as health education. We've all started to step forward and come together as that collaborative team. We even sprinkle some wound care in there as well. So with most of the time with our established patients, we can kind of do some face-to-face checks with the virtual visits, but really kind of pushing the boundaries and the limits as far as we can. So they're all done via virtual visit. And we've really kind of adopted, a couple weeks ago, we had talked about a plan A, B, and C process. So we've really continued to adopt that process. So plan A is always virtual visit. We preached that from the beginning. We implemented some scripting for our scheduling staff so that really we push and push and push for that virtual visit. And we make that the only option initially, and then we'll move to a plan B. And plan B may be an easier aspect like a FaceTime, or recently some of our providers have started to trial Doximity. Some are using Doxy.me. But from an organizational standpoint, we're really trying to push life size because we're trying to integrate that within our electronic health system to make kind of some of the meeting components and setting up a meeting a little bit easier. Today, I can report for us as well that we've also started moving our urgent care onto these virtual visits as well. So today's the first day that they're going live, and I was working there all day this morning trying to get those up and running. So we're really trying to limit the amount of patients that are coming onto our campuses daily, specifically with our patient demographic, like I talked about a little bit earlier. You know, higher risk, older patients, you know, are at higher risk right now. So we're really trying to focus on that. But we're also wanting to encourage them to get used to this platform early on, because this is something we're looking to adopt, you know, as we move forward out of this kind of COVID crisis. Next, the question is patient screened. So I believe this question is kind of related to how we're deciding if a patient should come in for a face-to-face. Can we do a telephonic visit with them, or can we do a virtual visit with them? And like I previously said, sorry, I'm looking over here and seeing that we have a chat here. Did you say we have a delegated person doing video visits only? I'll catch up to these here in a minute and try and answer some of those. Sorry about that, guys. Really, for face-to-face versus our virtual visits, the screening process is based off of how confident we feel the patient will be able to adapt to the technology. Some of that includes, you know, asking whether or not they have the technology available. So we have an older population that tend to function off of flip phones sometimes. So we'll ask further probing questions. Do you happen to have a desktop computer, or do you have a tablet maybe that you communicate with other people? Is there a family member near you who could help facilitate this visit? And really kind of ask some more probing questions. We've also found it very beneficial that we kind of what we call front load this process. So we're relying heavily upon our scheduling staff to really kind of be our super users for life size and to get our patients on board with this virtual visit process. So we found it very beneficial that we actually call the patient the day prior from the front office staff, and we do almost like a dry run with the patient. So we'll call, get them onto the system, and make sure that they're all set up for the following day. And that way, when providers are seeing kind of a high volume, there's no delay with the technology, because we have kind of found that to be difficult, especially if you're trying to see more than maybe 10 visits a day. We have some providers that are up to 12 to 15 virtual visits a day. And so they're really churning those patients through, and sometimes that technology aspect can really delay it. So front loading that process has been very, very helpful for us as well. One other thing that I kind of wanted to talk about is a way that we're kind of screening for face-to-face visits, or we often have nurse visits. And that's been something that's been difficult for us to kind of work through. So we have patients that may get allergy shots in the clinic, or patients that may get testosterone. We have other patients that will come in for Botox or those sorts of things from the neurology aspect. So those patients we're still trying to see, but we may be trying to localize them in more of a different aspect. But we're still running into those problems and trying to decipher those. Also forms, patients right now are out of work potentially. And so oftentimes these are forms that require PIN, to the paper. So we're kind of running into that and finding out different ways around that currently. So that's one of the big things we're working on now. The other thing that we're kind of running into is how to get patients receipts or even a printout from the visit. So through NextGen, which is our electronic health record, we do have a patient portal that we can enroll them in. So this week we're working through enrolling patients over the phone to get into our portal in order to be able to send out patient information. I think I've thrown a bunch in there. I'm worried about time. It looks like we've got about 4 minutes. So anything else that maybe I can add, or Christina, anything you want to do?
Let's see. I think you kind of talked about the documentation and coding challenges that patients bring up, but what about from the provider side, how they are able to meet those needs?
Sure. So currently we really haven't, we've tried to keep everything consistent with their previous processes. So we've really tried to sell this as, really the only thing that's different, provider, is that you're not having the patient in front of you to lay hands on. So we want your documentation to be much the same. And we recognize, you can't document in your physical assessment that, you palpated the abdomen, right? And you're really heavily relying on subjective information from the patient. So we've really tried to kind of steer them that way. I would say, they're documenting to the best of their ability. And the main concern is when they're finalizing a visit and they're entering in their office visit codes, it's really reminding them and getting them into the habit of entering in the modifier for it being a virtual visit. So we've got to retrain brains and get that muscle memory back, of trying a new process. So currently our team is working on a way to reconcile those visits. So I stated that we have a virtual visit and then a telemed visit, which is our telephone visits. We're pulling those two lists to reconcile them. And that's really the way that we're trying to capture those, but it's still all a learning process.
Mm-hmm. Thank you. And there was a question that from the chat. Was there a specific reason for your choice to use life size?
From our organization, I guess from my standpoint, what I can tell you is it was an organizational decision. It wasn't really a decision, that we made specifically. And so I'm sure that there were maybe financial reasons for it. I'm sure that there were other people that were already utilizing this under our umbrella that were already utilizing this system. So I'm imagining that was kind of the way that it kind of came down the pipe to us.
Thank you. And I think there was one more question about how you have delegated persons doing video visits only, if you could expand just a little bit about that.
We really don't have delegated people that are completing the video visits. We're really looking for, so each provider has an MA that works very closely with them. And so we've taken that team approach and essentially designed that MA or staff member that's close with that provider to be kind of their super user and that team approach. We currently have all of our primary care physicians off site now and off campus. And then just the support staff are here. So, we haven't really delegated them. It's really just finding those that are malleable to the systems.
Thank you. I think we have Maybe time for one more question and then we'll segue to Christopher. Have there been any connection or audio issues using LifeSize, and how have those issues been addressed?
So as with any platform, I think we're going to run into some issues. I will say that the majority of the issues that we're running into are really patient problems. So, I saw somebody else had mentioned something previously that with Android phones, they may be running into a different issue than they are with iPhones. And we are seeing that same problem, and it's troubleshooting those. So I will walk around the campus often just to check in and see how things are going. And staff will say, I will see staff and they're sending, you know, the links to each other, trying to figure out and troubleshoot and take screenshots of what's happening so we can understand the patient side. You know, we have ran into to those issues. We've also run into patients that maybe don't have the bandwidth to support it. And, you know, we've kind of adopted a 15-minute rule. If we can't troubleshoot the problem within 15 minutes, or if we start to feel that people are getting too frustrated, then we move to plan B or to plan C for the telephone visits. You know, the risk, not the risk, I should say, but with telephone visits, we have the potential of our visits not risk adjusting. So that's why we're really kind of pushing that 15-minute time frame and trying to get that video component on there.
Well, thank you. I think I'd like to just pause and see if there's any other clarifying questions for Jessica. And if not, then we'll take them after Christopher presents. Jessica, thank you. That was a fantastic overview. And I think you left a great amount of resources and considerations for others. So we'd like to move on to our next speaker. Really excited to turn it over to Christopher McGlone from Sharp Community Medical Group.
Yes, thank you. And hopefully everyone can hear me.
Yes.
Good. All right, good to go. All right, well, thank you to CQC for hosting these calls. I think they've been very beneficial to us, I know already, and our teams have been involved for quite some time. So it's a great place to share information that we can all can use. So background of Sharp Community Medical Group is an IPA, a pure IPA. When you think about that, all contracted physicians. We don't employ any physicians. Started in San Diego in 1989. So we have 30 plus years of experience in managed care. Started out in capitation, obviously. We are located throughout San Diego County and Southern Riverside counties. We have about 800 physicians, 225 of those primary care, in 350 separate practices. So we go all the way from solo practicing physicians to some groups as many as 80 physicians. That 80 physician group is an employed model that gets all their managed care and ACO type of agreements through us. And we also contract with 2 foundation groups who get all their managed care contracts through the IPA. Full professional capitation, 130,000 lives, about 31,000 of those are Medicare Advantage. We have a very small Medi-Medi population, but we also have a population under a straight MA plan that has Medi-Medis in it. You might have heard of that as an Assure plan or a look-alike plan, and so we are using that vehicle as well. We do have relationships with 2 hospital systems who also accept capitation on the hospital services side. So we do share risk with those organizations around quality and performance from their perspective. Revenues of approximately $310 million. We also have ACO agreements. We have 2 commercial ACO contracts. We have 1 APM model through an end-stage renal disease organization. And really we use that to help our physicians to get their MIPS reporting in, their quality reporting, and they have some benefits from a 5% bonus and other things if they achieve the goals. So that's been working well. We are fairly a comprehensive MSO from an MSO perspective. We've implemented EMR in about 75 practices. That includes a shared EMR and then a siloed practice management system. We're going to be switching that from Allscripts to Cerner in the next 6 months to a year. That's because the main hospital system, Sharp, is on Cerner, so we'll be able to incorporate all of that information in there as well. The MSO also does things such as case management. We have pharmacists. We do an anticoagulation clinic as an example. We have a team who are out in the practices working on practice transformation. I believe some of them are on the call today. So it's a very good team that gets out there and really works with the practices on how best that they can manage the actual ongoing care and the processes in the office to deliver the best possible, highest quality care that they can. Population health teams who are engaged. We have patient experience teams who are engaged with the practices. And we do have some telehealth that's already been working with a social worker that reaches out to patients and physicians that is based upon the hospital systems. InTouch is the platform that they use. InTouch just got bought by Teladoc, so we're seeing what that impact is going to be. One of the thoughts was with the InTouch platform is that we could roll that out to all the IPA docs when the timing was right. Then of course mid-March hit and we had some things change. So that's the background. What happened with us, and really it was quite amazing, I think, that mid-March all our doctors were able to pivot on their own with very little influence from us and begin implementing telehealth solutions. And they did it out of the necessity to maintain their practices and maintain their business. And they did it literally within a couple of days. So we were pretty impressed with how quickly they were able to switch and to be able to do that. And so it's been quite an experience, and I've been, as I said, quite impressed with that. Now, previous to this, we'd been using a third-party telehealth platform for our patients when they wanted a telehealth solution. They couldn't get it through their physician. We would use a Plush Care out of San Francisco who would do our, what I would call, tele-urgent care visits. And so there was access for our patients through that, but if they were an established patient with our practices, most of them did not have the ability to access their doctors via telehealth. There was a couple of practices that did, but the vast majority did not. And none were really doing telephonic visits, so to speak. But that all changed, and here we are where the vast majority of our practices are doing some level of telehealth, that's audio and video, as well as audio only, and it's working fairly well for themselves in doing this. Now, what are they doing that for? What kind of care are they being able to provide? Well, they're doing it a lot on the established visits, right? So they're working with the patients on the established visits, follow-up visits. They're able to work on chronic care patients, the chronically ill. We have been reaching out with our ambulatory care case management team to help them with those, with the chronically ill patients, to make sure that those patients are being serviced, because care does go on and needs do go on, and so we want to make sure that that's still happening. How are they screening those patients? Because most of the practices are maintaining their offices as well, and so they are screening them telephonically or via video, and then bringing them in when they need to be, and ensuring that they don't have any of the signs of COVID-19. So they're doing that. I can't think of but a handful of offices who are actually not seeing patients in the practice when they need to, so they're able to do that quite well. So we also have them now doing their annual health assessments. So we've been working with them. We just launched that in the last week, to where annual health assessments can be done via this telehealth, and we're actually incentivizing them to do that, providing more compensation for them in order to do that. Just as a note, our primary care physicians are all capitated for the vast majority of the things that they do, and we do have a incentive program based upon the quality metrics that can achieve as much as 40% of their annual compensation. So that's based upon a base cap, plus they're able to get incentives based upon how they actually perform against the typical AMP or STARS metrics. And then we're also having our teams and our practice transformation teams assisting and helping the practices fill their gaps in care during this time frame as well. So we do have a lot of boots on the ground, staff in the practices helping them with these type of the care issues. The type of platforms that they're using, Doxy.me is by far the #1 program that they've been using. It's relatively inexpensive, as I understand, for small practices, around $30 a month, so that helps. Some are using Zoom. Our concern with Zoom is that many have been using the free version, and we know there are issues with the free version. The healthcare version costs about $200 a month, so Zoom is a question right now if they're not using a paid version of Zoom. The other ones they're using are Skype, and then a lot of them are using FaceTime. And really what they do is if the patient wants a visit in a certain way, they're not comfortable using Zoom or Doxy.me, they will do it via FaceTime, they'll do it via Duo for the Android phones and things like that. So we see the practices really adhering and managing to what's easiest for the patient in many cases, but the vast majority are able to do it over Doxy or Zoom or Skype. And those platforms have been relatively easily and readily adopted, so it's very good. I think documentation continues to be a challenge. I think when I hear from physicians, they're trying to balance, how do I work with my iPad or my computer and still document the visit? So what we're hearing is that the visit, actually, the complete visit, which includes the documentation side, is actually taking longer than when they have the visit in person. So there are issues with that. Now I see a question here about PHI breaches. Yeah, we are concerned about PHI breaches, obviously. So we're trying to guide the physicians in that. So we are concerned about that, specifically around Zoom. I think there has been some waivers on some of the HIPAA requirements. I think FaceTime has one of those waivers. So other things that we see for our practices in terms of best practice, one of the things that we've been able to help them with is what we call webside manner. So rather than bedside manner, webside manner, we have a document that we've pushed out to them, which is one of those things even I'm having a challenge with today, is always looking right at the camera versus looking at the images of others or the patient on the screen. So I think that helps, and so we've been able to give them some feedback on how best to approach having a web visit with patients and what patients are looking for. We think that it's going very well. We think some of the documentation or some of the resources that you provided at the beginning of the call, those are where I would point you to, be it AMA, I think has a very good one. CMA has some great resources, and so that's really been very helpful in what we're trying to do. The barriers from the patient side have not been great. Most of our patients seem to be able to access these either the calls or the video. Again, our doctors, and this is, I'm making a kind of a broad generalization, are able to use whatever the patient is able to use. So if they're not able to use it, they'll they'll be used telephonic. So that's been very helpful. We think that the nature of where we are as a society, from the perspective of grandparents FaceTiming with their grandkids more and more, so that seems to be a much more acceptable technology than maybe it was 5 or 10 years ago when we first started talking about telehealth and telehealth platforms. So that's what we've been able to see in our in our environment. So with that, I'll turn it back to Christina and see if there's any other questions or things that you want me to cover.
Thank you so much, Christopher. So at this time, I encourage all attendees to chat in your questions for both of our excellent presenters, or feel free to press *6 and unmute yourselves. We do have a question that just came in through the chat for, I believe, both speakers. Are you being reimbursed for telehealth visits?
Well, I don't think we've seen the reimbursement flow through yet from the payers. We're just trying to, as a payer ourselves to our physicians, we're trying to get out that guidance as soon as we can. But literally the information and the guidance has changed on almost a daily basis. And so I think we finally landed on a finalization, and we're going to get out to our physicians today how to bill, whether it's Medicare, whether it's TRICARE, or us for that matter, and how compensation will lead from there. So I think it's too early to say whether we've seen reimbursement.
Great. And Jessica, what would you add?
Yeah, I would agree with that as well. I mean, we haven't really seen reimbursements coming in, but as a, kind of a full risk from our employed perspective, it's a little bit different from there. But yeah, we haven't really seen too much, but I agree they are changing day by day. So we're just kind of going with the waves as they come.
Thank you. We have a few other questions that came in about coding. I think, Jessica, you might have spoken to this, but maybe there's more specificity you'd like to add. Are the codes different? Do you have a different way in coding these visits? And then what about for home health and telehealth? Are any special codes being used for these?
So I can't speak to the home health component, but as far as it goes with coding, we're following our normal CPT codes for office visits, and then adding in that 95 modifier, which states that it was a virtual visit or a telehealth visit. We also, I believe there are some other codes. I believe it's a 944, 12, 13, and 14, and those are your telephone codes. So when we switch to a telephone visit, those are the ones that we're using there as well. And so that's kind of that aspect from, I guess, the billing side, from what little I know of the billing side, but I do believe that that's the way that they're doing it. I think Christopher talked about annual visits as well, and maybe for your HCC coding and risk adjustment. We're moving towards that way as well, and we're encouraging our providers to continue with their annual visits so that we can continue with that process as normal. So that's all kind of continuing still.
Christopher, would you add anything about coding, especially around home health or telehealth?
Yeah, I think in terms of home health, I don't have any information on that. I know that the DMHC has offered, as well as Medicare has put out, or CMS has put out a lot of guidance in terms of billing and the codes. Like I said, we're finalizing ours right now. I think our biggest challenge has been around the copays, and I see those questions on copays. Correct, a lot of the plans have come out and said that there will be no copays for even non-COVID related treatment. So that may be a challenge, especially to our primary care physicians who are capitated for their E&M codes, and then they're not able to collect a copay for that visit, which they kind of rely on that revenue as well. So we're going to come out with our guidance, which will follow mostly that there will be no copays for telehealth visits within our HMO book of business. And you'll see that I think Aetna and United have done it. I think even on PPO business, and Cigna might be following suit. So that's the type of things that need to be tracked almost on a daily basis, is what's the updates from the plans in terms of what their payment policies are going to be. And so that is a challenge.
Christine, I would just add into that as well that we're definitely running into the copay issue as well. And we have taken a stance to kind of follow along the same lines as Christopher is saying regarding, potentially waiving those copays or not charging the copay. But we are working through that process right now. And one of the biggest difficulties that we're finding is we're able to take the copay obviously over the phone and enter in that information for the credit card or whatever else is used. But what we're running into is how to get them the receipt. So that's been one of kind of the barriers that the team is working on today diligently in the background, is figuring out, like I said, through the portal usage, if that's something, the way that we can kind of allow that as well. But we are hearing the same thing with United and Aetna also. And then it's also anything COVID related. So we're having to kind of screen those also a little bit more.
Thanks. There's another question that came in about annual wellness visits for child well visits, and follow-up question on what type of visits are pediatricians doing to lower volume than immunization or family practice?
We don't have any peds in our IPA, any pediatricians, so I cannot answer that question.
So we currently do have a couple pediatrics. I can speak for the one that's kind of under my umbrella right now. And we're trying to do most of these visits virtually as well. But those are kind of the things that if they need a vaccination, we're bringing them into the office as a nurse visit for those vaccinations. So it would be a virtual visit over the phone with the pediatric provider, and then once again, bringing them in for that vaccination.
Thanks. Our next question is curious about any happy surprises or unexpected positives that have come from massive and rapid uptake of telehealth that you've observed from your practices.
Well, I think that, oh, go ahead.
Oh, I was just going to say, I can tell you just from one perspective with the older demographic, I think that there was a concern that maybe people in their 90s couldn't get the virtual visits to work or anything like that. And in fact, we had a report back from one of our IPA providers that they were able to complete the visit flawlessly with a 97-year-old. So I do think that that's been something that's been exciting to see. And as we kind of continue, we are expressing those things to our other providers to continue with the positives. I will also say that some of the providers that we expected to be naysayers have actually been some of our biggest champions in this process. So those were pleasant surprises for sure.
Yeah, I'd agree with what Jessica says. I think that's the adoption both by the physicians and patients has been great. I think this will be a paradigm shift in terms of how care is delivered. But some of that is really based upon how payment policy is going to change potentially. If docs decide to do more of what they would do in their offices now via video and audio visits, the compensation needs to follow in order for this to continue with that paradigm shift. But the physicians have been really amazing in accepting it, as have the patients. So I'm very excited about what this may portend for the future.
Mm-hmm. It sounds like there's no need to underestimate anyone. Everyone's rising. I'd like to call out a question that came in from someone that registered. They were wondering if there were any technologies that the organizations have implemented or adopted alongside telehealth platforms. So these could be to supplement patient outreach, document exchange, or billing.
So I can speak to that a little bit for our organization. As I mentioned, we utilize Well as appointment reminders and texting. So what we have implemented is when you choose that event type within our practice management scheduling system, it sends out that automatic text reminder to the patient, and it introduces them a little bit further into the virtual visit platform, tells them kind of what to expect. And then if the appointment is out at 7 days, it'll send it at 7 days. Then it'll send another one at 2 days, another one at 1 day, and then another one an hour before. So they're really kind of getting hit with a bunch of them, but it is getting them used to the texting link, because we do send the link to the patient for the meeting via the text. So it's the platform that we utilize to do that. It's also a way we send out mass campaigns. Mm-hmm. So we will send out, for example, with COVID when it first came out, we wanted to send out blast information. So all of our patients are verified. They may not all receive the text messages, and some of them have opted out, but it is a platform that we utilize to campaign and get information out. It's a way that we also get our surveys back in. So now we are going to begin polling on our virtual visits and seeing how they went and getting feedback from the patients as well. Mm-hmm. As we continue to develop. We have also been, over the last couple of days, like you mentioned with the forms, working on other aspects. We did find out that EDD is all online now. So that was one thing for disability paperwork that we're able to help facilitate with our patients, which was something we did not know until this morning. So that was some good information for us. And we're working to find out if there's anything about, the use with the DMV. Is there an easier way to sign some DMV forms as well? So those are just some things that we're working on in the background also.
And I think the challenge will be as we move forward. I think how do we engage the patient portal that we're already using, since we don't have really a comprehensive entity-wide or system network-wide solution. How do we integrate what the doctors are using with our core EMR and or managed care applications? And so that's one thing we'll be looking to see is, do we need to take a more not a decentralized approach, but a more centralized approach from the IPA perspective. What we found is some of those centralized solutions are very difficult to implement, aren't user friendly. And so I think what we've learned from this experience is physicians are certainly willing and accepting of new technologies, but they have to be easy to use, because physicians need to be concentrating on the clinical care, not on trying to figure out how to click screens or click ellipse boxes or whatever it might be. So that's I think something that we'll have to, we'll see how that's going to all fall out.
Well, thank you to you both. I think you both provided such depth of information, and I think the number of questions that came in shows how hungry people are to hear more. I will say you have an audience of peers and partners on the line. Is there anything that you would like to pose, questions that people can chat in or share their responses?
I don't think so from my perspective. I just really appreciate this opportunity to share what we've been through. So thank you guys very much.
Thanks, Jessica.
And I'd love to hear how some of you are dealing with the challenge of documentation in the EMR while physicians are using an independent telehealth solution. I think that's our challenge.
Thanks, Christopher. So I encourage those on the line to share right now in the chat how they are approaching that challenge, or I'll pause right now to see if anyone would like to join through the audio, unmute themselves. Well, thank you again to Christopher and Jessica. We're going to go ahead and provide a few more updates before we close. So let's go ahead and advance the slide. I wanted to call out a few other opportunities and resources that are also included on our CQC resource page. The first is an FCC funding opportunity, which is $200 million in federal funding to improve connected health services. I believe there isn't an application deadline, but I believe that the funds may be first come, first serve, so do check that out quickly. There's also a CMS update we wanted to share regarding diagnoses from telehealth services and risk adjustment. So check out those resources and other resources, and always feel free to recommend additional ones that we can post to our CQC website. The other announcement I wanted to cover was that the Primary Care Collaborative is doing weekly surveys on impacts to provider organizations. So, take this survey if you have a chance. We would love to be able to share, and this is on the next slide, thanks Jose. We would love to be able to share some California specific results that PCP could run for us. So share this link with your provider organizations and have them tell what the impact of COVID has been on their systems. Finally, we would love to run our final poll, which is how this webinar served your needs. And while we're running this poll, I wanted to announce our next webinar. We are very, very pleased, and Jose, if you wouldn't mind going to the next slide, very, very pleased to announce our next webinar in the series, which is with Sutter's Terra Practice. They are a virtual first practice that have been in operation, and I believe that they offer 95% of their visits virtually. So we're going to have two speakers from that organization on our Caring for Patients Virtually, Lessons from a Successful Virtual Primary Care Practice webinar. That will be on Thursday, April 30th from 11 to 12, and you can register in the link that Michael's providing in the chat. We are really excited to hear what use cases you and your provider organizations are struggling with when it comes to delivering virtual care, because the Terra practice is going to answer as many questions as they can in the course of this webinar, and the speakers are really excited to share how they do wound care and other sorts of chronic care management issues that your practices may be trying to figure out right now. So with that, I'd like to close and thank our speakers, Jessica and Christopher, one final time, and thanks to the CQC team, and thanks and take care for all of you. Goodbye.